Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I have the pleasure of being joined once again by two guests, Drs. Claire Ferrari and Allie Larios. Drs. Ferrari and Larios co-own and run Ferrari Larios Orthodontics in Kensington, California, where their motto is Breathe and Smile, a whole body approach to oral wellness, a motto I absolutely love. Some of what we discuss on today's show includes the need for orthodontists to develop a more proactive, whole health approach to patient care, and why the AAO and orthodontic residency programs are not getting behind this more proactive approach, what types of issues should be addressed early, and the various diagnostic and treatment approaches one can use for pre-adolescent patients, the numerous benefits of CBCT imaging, and why, for some reason, it remains a controversial topic for orthodontists, whether tooth extraction causes airway problems, how to develop a network of trusted medical colleagues, the role of corporate entities and venture capital investment in dentistry, and why Drs. Claire and Allie have decided to pursue a more traditional business model, what they see as the future of the profession of orthodontics, and much, much more. So without further ado, let's get on to today's episode with Drs. Claire Ferrari and Allie Larios. Enjoy the show, everybody. Welcome to the Doc Podcast, Claire and Allie.
Thank you.
Thanks for having us.
You're very welcome. Thank you so much for coming on. By the way, before we start, I love the acronym of FLOW of your Ferrari Larios Orthodontics. Love it. I think it's like a triple meaning there. Obviously, your initials and then finding your flow state and then airflow. I don't know if I'm missing something, if there might be more of that, but when I saw that, I was like, that is great. Flow.
Right? Yeah. I'm really excited about it. Yeah.
Really well done.
So one of those moments we realize it just works perfectly.
Yeah. I looked, I'm like, flow. Oh, that's pretty cool. So that's awesome. So
Thank
just before we
getting it.
You're welcome. I love little subtleties like that. Before we get into the content, what we're going to be talking about today and kind of leading us into that content, if you would both share a little bit more about how you each got to this place in your careers. Claire, you're the senior doc and you've had this practice for 10 years and Allie joined you in practice approximately 3 years ago. So talk a little bit about, starting with Claire, how you got here. What's your journey been like in this profession? I know when we've spoken before, you mentioned you have had the opportunity to learn under some of the legends of our field, Prophet, McNamara, Kokich. So talk a little bit about your journey to this point.
Yeah, I've been really fortunate in the mentors that have guided me along. The first one was actually my father, and I worked with him since I was 12 in his office. And he was very much on the leading edge of doing early intervention, and he did expansion, phase 1 expansion before it really existed. And then he felt so gratified and heartened by the fact that it was being taught. And when McNamara started talking about it, I used to go to the meetings with him, and he would go over and talk to Jim. And so they developed a friendship, and he just would say how heartened he was that it was now being taught and being shown to have value. Because there were people who said to him, like, what the heck are you doing? Like treating people in the mixed dentition. And he even said to me many years ago, he said, I swear they're breathing better. But that was like completely off the radar.
Isn't that funny? Yeah.
At that point. But interestingly, it had been on the radar very early in the profession.
Right. It had fallen off the radar, so to speak.
Exactly. So then when I went to school, I went to dental school at the University of North Carolina for a year and got to know Bill Prophet and, was influenced by him. And then I shifted and finished my dental training at University of Michigan. And I actually thought I was going to go into OMFS. And then I shifted my thinking and decided actually to go into ortho after living in Ireland for 2 years and went to University of Washington. And I was really surprised at how often the treatment plan, the discussion was around basically I'm not going to say it was always around which teeth to extract, but it was very common that in the treatment planning options were extraction patterns. And of course, there was the whole thing of the irregularity index and teeth getting crowded over the lifetime of the human. And I was always the one that was like, we could expand, like, don't go beyond this limit. And I'm like, why? Am I a freak or what? But I always felt like it looked better, and it was there was something very visceral in a certain way. Like, I think it's just a better outcome.
Yeah.
Because I remember the patients, day in and day out that my dad treated. Yep. So that was my comparison. And I just happened to have that influence for many, many years, because from 12 to, 19 or whatever, I was working with him. And then when I got out, I was working in craniofacial anomalies for 3 years at UCSF. I did a fellowship. So I was very much focused on kids with craniofacial anomalies. But I also just cared about like what we were doing as a profession and wondered how could, what are the things that we're influencing? Because I was very interested in growth and development in general. And then when I shifted and worked in a group practice, in private practice, it was, again, I felt myself in that situation where I'm kind of the outlier, not wanting to take teeth out.
Are you in your dad's practice at this point, or?
My dad's on the East Coast. So I was living in California.
Okay, got it. So you're in you're working for someone else in a practice on the West Coast.
And
okay.
I didn't actually want to own my own practice. Like, it just wasn't a desire of mine. And I was working at a group and teaching and doing craniofacial anomalies, working in a children's hospital in Oakland, having kids. I had 3 kids. That's a full-time job. And then over time, when my kids got older, I started working with Sean Carlson for a while.
Nice, awesome.
Then it was like all CBCT. And I could absolutely feel how blind I felt when I didn't have access to the CBCTs. And I think you cannot know that unless you are exposed to both and you see how blind you are.
Yes.
And so that was, again, a unique opportunity, because that's weird, that I was in a situation where at one, office it was everyone, and at the other office it was no one. And basically it just became clear that I had to start my own practice. And Sean encouraged me to do so. And this centerpiece of the figuring out the layout of the office was the CBCT.
Yep.
Right?
Yep.
And then, it was very clear also, and Sean was really good at developing information for parents to understand why it's not dangerous, the level of exposure is not greater, it can even be less. And the information we get is just, it's unparalleled, we are 3D humans.
Right.
The idea of looking at 2D imaging and doing diagnostics is crazy to me.
Yeah, you're so right, because I've looked into the history of this, and cephalometrics evolved from craniometrics in anthropology. And what they wanted to do was get a radiographic image of these skulls. So initially, when Broadbent initially proposed the first cephalometer in 1931 at Case Western, it was it was 2 separate 2D images. It was actually, they took exactly, your hand's perfect, exactly. They took a PA and a lateral with a patient static sitting in one chair, not moving their head. And then there was mathematical computation that was done with those data points to create a 3D analysis. People don't realize that. So we knew going back 100 years ago that we should try to be looking at our 3D bodies in 3D, right? Go figure, like you said. And that we shouldn't be dumbing it down and losing a dimension. But what happened was, it was actually, if you go back and look at this, it was market forces, which so often play a role in this. It was too costly, and it was too much space in the physical space to have these 2 fairly large X-ray heads, cones in your operatory. So it literally got watered down to just a single lat sep. And then back then, some were taking a lateral and a PA still, but the patient moved. You had to move the machine and move the patient. So you no longer could create the mathematical computations to get a 3D analysis. And then it took actually almost 3 decades into the mid 1900s towards 1960 until cephalometrics were accepted by the profession. And now they're gospel. And it's like, God forbid you ever question someone and say you should do 3D instead of 2D.
Right. And then the question is what humans were used to create those norms, right? That's really a very
great point. Yes.
And the whole post-industrial growth and development versus pre-industrial is so important. And again, like I feel so gratified that my, mentors were people like Prophet and McNamara and Kokich at University of Washington. I love them. And I feel like there is an evolution that's beyond the very exquisite carrying out of orthodontics for the alignment of the teeth. Mm-hmm. Yeah. When I'm opening up an image, the very first thing I look at, well, I always joke this way, the first thing I look at is the tongue and the nose. Mm-hmm. It's not the teeth.
Right.
And I think it's so important that we understand where we are in this structure on the human skull is plays a role in the body in a very big way.
Yeah, I literally just wrote those words. It's so funny hearing you say that because I have part 2 of I put part 1 was in Orthotown in March about looking at the difference, why we need to focus on sleep disordered breathing instead of obstructive sleep apnea in children. Why we need to talk a little bit about that too. And then part 2, which is coming out, I just finalized the transcript. I think it's going to come out in June. It's talking about how to start to screen. And we'll talk a little bit more about that as we go on today for these patients. And one of the things I said is I would be willing to bet that the vast majority of my orthodontic colleagues, the first thing they do in their clinical exam is put the patient back, look in the mouth, and look to try to see what class molar they are. Right? I mean,
and that is so funny because my treatment coordinator actually still calls out. She's like, classification. And there's something like my eye kind of rolls like, that's not important right now.
Right. We jump right to when residents come to me, I'm like, okay, they come, class 1 molar, endon class 2, and this much overbite. And I'm like, but what about their face? We don't often have a CBCT, unfortunately, yet at Nova. We're working on that, but we have one we can use, but it's not our standard imaging. And we can talk a little bit more about the state of academia as it pertains to that in a bit. But like you said, I feel blind. I'm like, but how are the nasal passageways, what's the adenoids, the pharyngeal airway? You just,
what? And also like health history form. Like, what are we asking?
Thank you. Yeah, I mentioned that in the article too, that we look in orthodontia. It's so nice to have this conversation. In orthodontia, we tend to focus on a very brief, cursory medical history, I would say, for most of our pediatric patients. We look it's the major systems. As long as there's nothing flagrant or that screams out at us, a congenital heart issue or something they're going to need prophylactic antibiotic for, something of that nature, we tend to just look through it very quickly and then jump right into looking at how this child's teeth are growing in. And we don't take the time to go through that. So we'll come back to that too, because I want to hear after we go through the backgrounds of more about that part of the process in your practice for sure.
Yeah.
Well, that's that screening that you're alluding to.
Yes.
Screen for these things, these conditions.
Yeah. I would definitely want to come back to that more. So then how did, Allie, you coming into this, you are 4 years out, right, of your orthodontic residency. So talk a little bit about what you learned in your residency as it pertains to some of what Claire and I were just starting to speak about, and then how you found Claire and how this has been since.
So I was lucky in that I went to UCSF for my residency, and we did take a CBCT on every patient.
Oh, it's so awesome.
So I started my career, my training looking at 3D. So it's interesting because you two are kind of talking about your experience being in one, and I did when I started private practice, I had 1 year of being in 4 different offices, all treating differently, some using CBCT, some not. So I didn't really have a decade of like, just, feeling like I was looking at one thing one way. And now I'm just discovering this. I kind of always was seeing it that way. Mm-hmm. However, we weren't using that CBCT the way we're using it in our practice.
Oh, interesting. Okay.
We were given so much information, but I don't remember really diving into like the tongue. Where's the tongue? We're like, let's look at the pharyngeal airway. How's the head position? You know, we learned what the head position should be, but now that might not how that might affect the airway.
Yep.
Rendering little things like that are really important to make sure that when we read the image, it's correct. Yes. And we know the limitations. So I was very lucky that I developed my visual of this is a 3D image. But we still looked at pianos on the 3D. You know, it was like, let's look at the piano. And so like, why did you do that? So that's what was happening. And so, but again, I did start my career that way. And in residency, I remember I had a faculty that we were treating a case together, and he was like, there was an open bite that we couldn't close. And he's like, it's the tongue. And I was like, okay, but I was so confused by that because that's kind of all he said. There was nothing else about, well, how do we manage the tongue? And why is the tongue fighting against us? Did we start this case correctly? Because we just put braces on, you know, was there a better way to approach this then? Right. I wasn't thinking that way at the time, but I just remember that case with that faculty because he said that, but I just, as a student, you know, to just have that said to you and not really go beyond that was really like, what?
Yeah.
I guess it's the tongue, but I don't know. I'm just going to keep closing these spaces.
Right. Back to the teeth, right? Well, yeah. Focus back on those teeth. Yeah.
Exactly. So, so when I started private practice, I, again, did have a mix of different types of offices that I was working at. I was with one woman who was talking about the tongue and looking at tongue ties, referring to myofunctional therapists. That's when, you know, the whole, like, when you see it, you can't unsee it. That was me in that first year. So I'm got very lucky. Like I saw it, I started, but there's so much to it, right? It takes like a lot of CE, talking to their colleagues about what they see, you know, a lot to learn how to practice this way. Yeah. And then the way I met Claire was one of my really, really good friends was working with Claire and was deciding that she wanted to work not in Berkeley and elsewhere. And I actually went to Cal, go Bears. And my dream was to bring me to work in Berkeley. So she's like, hey, how do you feel about working in Berkeley? I was like, yes. I knew about Claire. Again, this is one of my closest and not best friends. We talk about orthodontics and how she was practicing versus how I was practicing, what we were seeing. So I knew what the practice was like, but when I was here, I was like, oh, this is next level. Compared to, again, I saw the whole, I started to see things, but it was like, all right, now we're like really doing things, doing in a way that I didn't know orthodontics could be like this, where it's whole body, you know.
Describe that a little more if you would. Go into that a little more detail if you don't mind.
Well, when for example, we talked about the health history form, we're asking questions, not just about, we're looking at the patients and we were looking at the teeth. We're looking at the image, Claire was talking about the nose and the tongue, but the question on the health history form are about how they're doing, like how their systems are doing, how their nervous system is. We see the patient in the chair and can kind of gather some of that data ourselves as well. We're working with teams of like, you know, the myofunctional therapists, the ENTs, the allergists. I've been on a phone call with an allergist, you know, or like these different professionals. It's not just the endodontist, you know, it's like beyond the dental field. So we really, I have a limit to what my knowledge is, and therefore I know I need to rely on some of these other professionals to help us understand our patients, not just their mouth and their occlusion and all that, but their whole body. Yeah. So by getting more data from asking the right questions, getting our 3D images, that helps us create these questions that we may sometimes need to ask other professionals about. Yep. And that's where it's a harder way to practice. Yep. You know, it takes more time.
It does.
Our doctor time, like on our schedule, is, you know, it's more, I'm sure, than
Yep.
the average practice. There's two of us, and
To that point, I've told this on a couple podcasts recently, so some people may have heard this, but it's just so profound to me. I feel the need to keep saying it because it keeps coming up and is so relevant. I was giving a full day course in Cleveland to an interdisciplinary group. It was generalists, specialists of all types of dentistry, a big study club up there. And I asked, because I was exactly what you're saying, I couldn't agree with more. One of the deterrents I feel to our colleagues, and we'll get more into this, but why they're not doing this as much is it's harder. Like you just said, it's harder. It's wonderful. It's gratifying. It's amazing how much better your cases are and your patients, their health is. That being said, it's a lot more time in the diagnostic process. So I asked the orthodontist in the room, I said, how long do you think the average orthodontist spends in a consultation? What do you guys think the answer was, with a consensus?
Wow.
What'd you say, Allie?
Wait, yeah, that was probably 2 minutes.
You guys nailed it. 1 to 2 was the answer.
Well,
Yep.
wow.
Well,
Yep.
in some of those consultants, they're like, the longer the doctor's in there, the worse off you are serving the patient.
Yeah.
Yes.
We have like 20 minutes of doctor time.
We're like a long time.
Yeah.
And then for some, I mean, especially for the adults, they'll be like, go out and get all that information, come back, and then let's discuss the options. Because what you open to, I mean, I'd rather talk about kids, but the adults are quite complicated.
Mm-hmm.
It's almost like, is this going to be a subset of the profession?
Yeah.
That's what I sometimes wonder.
Yeah.
Because when I started my practice 10 years ago, I said, it'll be the norm in 10 years. It just isn't yet.
It's
and
not.
Now I say, it'll be the norm in 20 years.
Yeah. Yeah, I think there's too much, like you said, market forces, right? Why CEFs became 2D. Market forces are against this from the perspective of we bill for our procedures. We don't bill for our diagnostics. I mean, our codes are procedure-based in dentistry in general. And we are notoriously poor at billing for our time as orthodontists, right? So how do we make up for it? We bill for volume of procedures. So the system's almost set up to be just an inherent deterrent to people doing this.
Yeah. And at this stage, the way we are doing it is that it is much more time and energy that we spend on our patients and the interaction with other professionals. Like, it is much more time and energy.
Yeah.
And we charge for it.
Good.
And people come from a distance, right, to be able to get that kind of care.
Yep.
And there's an element of, for us, I don't even see it as, that's a patient who's got a particularly bad issue, they should come see us. I mean, some of that is true. Mm-hmm. But if you look at facial growth and development and breathing, my father was an orthodontist. I never had orthodontic treatment. My siblings did, because I had perfect class 1 occlusion. My teeth were straight, a great smile, whatever. Like, I didn't need it. Mm-hmm. When I was in my residency, I remember my dad saying, I wish I'd expanded you. And I was like, what? Like, why? Now I'm like, oh my God, I wish I had like 5 more millimeters. I'm like hyponasal. If I could just breathe better through my nose, it'd be amazing. I'm going to do it on myself. Allie's going to do it.
That's where it's great to have a talented co-doc.
The point of that is more like, if you start looking, it's not because you're not looking because like, we can make a buck. It's like, we aren't growing as wide and as forward as we used to as humans. And
Thank you.
If you start looking, you will see it everywhere. Yeah.
Yeah. And I think don't you think a lot of people are just afraid to start looking? Don't you think that's a big part of it? Right? Kind of head in the sand.
That's the whole point of even the CBCT argument. Like, don't make me responsible for that. Like, are you a healthcare professional or not? And if you need to have like a disclaimer when you're taking the CBCT, like, I'm a dental professional. If you want this evaluated by a medical professional, we can send it for a radiology report. Like, sign here. I'm not looking at da-da-da.
Right. Or at the very least, because some people I've heard say from the legal side, you're responsible for it, then charge your patient an extra, you can send these things out to be read now for $55 to $85 if you really don't understand it, especially early in your career. And I say that when I teach all the time. I mean, I didn't send mine out because I went and met with my ENT and allergy colleagues and I had them teach me how to read these. But if you don't have that knowledge or that ability to go do that right away, there are courses out there. But if you don't, then until you get comfortable, send them out, charge the patient, say, because this is a more advanced image, I want to make sure I don't miss anything. And honestly, if you've gone through 4 years of dental school and 2 to 3 years of an orthodontic residency, I don't know, after you see maybe 10 of these things come back with a radiology report, you realize it's really not that complicated. It's really easy. And when you see something abnormal, then you refer it to OMFR or to oral surgery, just as you would with a 2D image. People are so intimidated by this. And when I teach, especially residents, they're like, that's it? This isn't that hard. I've heard CBCT was so hard.
Like fear of nothing in a way, right? Like,
And it does. What I've found for myself is the more I do spend time looking at a CBCT and I'm noticing like the C1, C2 relationship in the spine, like, oh, you know what? I have a limitation on what I know about this. Let me ask a physical therapist that we work with. It helps me realize what my weaknesses might be and then challenges us to want to know more. And that's what we should be doing, right? You always wanting to grow. It's a practice. We're constantly practicing. But if you're just kind of doing the same thing over and over again, it's easier. But I don't know. That's just not how I want to practice.
Yeah, and you can make a decent living at it, right? You just charge what you should charge. People will come. It actually, we are way more. I'm going to have to knock wood under here, but I feel like we're way more resilient to the market forces.
Thank you.
Because people want this care.
Yeah, I'm so glad you said that, Claire, because we are running businesses. And I think a lot of the orthodontists that say, oh, you're just doing phase one to make money. I actually say the orthodontists who don't like doing phase one, they don't do it, a lot of them, because it doesn't make money if you don't know what you're doing and how to do it. And so it's very ironic. It's kind of gaslighting at its finest. It's like they haven't figured out a way to monetize phase one. So they're like, well, it's just to make money. No, if you do phase one poorly or inefficiently or ineffectively, it is a drain on your time and resources. And then your patients need super comprehensive phase two. And they're like, why did I even pay for that phase one? And that's why a lot of people, I feel like it's a deterrent to do phase one. If you really understand and get into the diagnostics and the holistic whole health approach and really transform the growth and development of these patients young, they grow so well and so easily. Phase two, if they need it, is a layup. And you've done such a better service for this patient's overall health and development. And I have to say, and I don't say this, I say this proudly, not arrogantly. I have a colleague who practices in the area I used to practice, and she just texted me the other day and said, I just had another one of your patients come in that you did phase one on, because when I phased out of my practice and went into academia full time, obviously I had patients that had phase one with me that I didn't get to do their phase two. And she's like, every patient I see that you did phase one on looks amazing still, and they don't need a ton of work. And that's not, those aren't my words. And again, I don't say that arrogantly. I just say it because this is not me, cherry picking cases. This is a colleague in the area I used to practice who's texting me randomly to say, like, this is crazy. Your phase one cases look amazing when they come in as teenagers. So it's not that it was anything special about me. It's that I took the exact approach that you two are taking, and it works.
Well, when I was, again, I had only 1 year before I met Claire, but I remember having such a hard time with some of these cases that I saw. I'm like, but the teeth aren't fit, like the occlusion, like, why is this so hard? It's so hard to finish. And it's because
you're talking about like comprehensive cases or like adolescent cases that
they're freezing on a 13-year-old and we're just not finishing well. And it's because the coordination's off. The upper jaw is narrow. And so how do you get the right? Okay, they're done. You couldn't correct the class 2. Try, they're straight. So when you make the upper jaw the appropriate size to meet the lower, everything really just comes in so easily. It's what your colleague is saying.
Yeah. And McNamara said that in his maxillary transverse deficiency article in AJODO in 2000. He said that it is that occult maxillary transverse deficiency is the most under and misdiagnosed thing that we have in orthodontics. And to this day, the AAO, when I applied to give a lecture, I taught, Claire's got the
constantly like, see this, the maxilla, it's two bones and we're widening it.
Yep, you got the skull at the ready. I love it. When I had the AAO tell me that when I was going to talk about early treatment and recognizing sleep disordered breathing, they have told me they don't want me to speak at any of the meetings because they're afraid, and this is a quote from them, they're afraid I'm going to promote indiscriminate expansion, which is orthodontic code or AAO code for expansion in the absence of crossbite.
Oh my God, no, that's still thought of
I just had that said to me. I applied to speak at the 2025 winter meeting, which was just a couple months ago.
There's research on this,
lots of it.
Yeah.
Lots of it. And I go over that in my lectures too. And not to make this bashing the AAO or any one organization. I just feel as my audience knows, I call balls and strikes on this stuff, and I will say what I feel is true and take the blowback for it. But I'm just commenting with my opinion on this. I looked at the virtual lecture series for AAO, which is actually going on as we're recording this. So get this. When the Friday, Saturday, Sunday lectures, this year it looks they did it a little differently. The virtual lectures are not everything anymore. I think that they just kind of created pathways for the virtual. So I honestly don't know about whether this applies to the in-person. I haven't seen that schedule, but there were dozens and dozens of lectures on this virtual lecture series that you could watch. Not one lecture mentioned what I call the A word, Airway. Not one. And not one lecture mentioned CBCT.
That surprises me. I thought it had been in the, we were at the WOCON meeting. What was it?
Yeah.
Right in October. Yeah. There were actually a lot.
That's great. I don't know why the AAO is running from it. I know their scientific committee, the people on it, my understanding is that they have a more traditional view. It's a pretty small scientific committee that determines who gets to speak at these meetings.
I know the people who were doing the, because Katie was part of the, yeah.
But I know last year they had a few, but that was the in-person. So hopefully the in-person schedule is
maybe that'll be
what you have.
I hope so, because these are the hot button issues of our profession. And I know after Audrey Yoon and Rebecca Bacow, who've both been on my show and are great, after they spoke about Airway more openly and about what we're going to get into momentarily, about going in and treating these kids younger, they were, borderline harassed by a lot of our colleagues for what they spoke about at that meeting. And they're both too nice and too sweet to make an issue of it. But I'm much more direct on this stuff.
They did a Markby symposium actually yesterday.
Yes, I hear it went
hopefully
really well.
Did, start the discussion for the weekend. But
yeah, the AAO is going to find itself irrelevant. Everything was about aligners and tooth alignment, and I get it. That should be part of it as well. But to totally jump ship on this, and as much as that winter meeting that was with the pediatric dentists, there was just a few hours on the last morning devoted to Airway, and I was so disappointed because the topic was, I think it was the role of the orthodontist in the diagnosis and treatment of OSA. And I'm like, oh my gosh.
Only OSA, yeah.
What in the world are we doing?
I don't understand it, honestly. And what is going to happen if we don't take the mantle of growth and development? This is our bailiwick, right?
Yes.
We are orthodontists. It's about growth and development. And if we don't do it, the dentists are doing it, right? And they don't have our training. So that's really what's happening is you see this kind of fringe stuff happening, and some of it's not 100% fringe. I'm not trying to just paint it all as negative.
No, I know some that have gone through a ton of age. Yeah. No, go ahead. Yeah.
No, there's some very negative stuff happening because we aren't taking it on.
Yes.
And we're running away in some way from it.
Yeah, and I just episode couple times preceding you with general dentist Jenna Schwibner, who was a very successful restorative dentist. And she said, I didn't want to do this. I was begging my local orthos to please do, because she started learning about it, seeing what was happening. And I can't tell you both how many people have told me this in person and on my show and said, Mike, I didn't want to do this. This has made my practice so much harder. I've had to go to weekend CE meetings and I'm constantly traveling to learn. But once I saw this, or I saw it in my own kids, and I was begging the orthodontist to try to be more proactive, and they just kept saying, no, wait, we're not going to do anything. She said she even brought an ortho into her practice, hoping, well, maybe if I bring one in, I can have them. And within 3 months, the ortho refused to treat anything early. And so she's like, I had to let her go. And now she's literally gone from working 2 to 3 days a week on mostly retirees in the East Coast of Florida to working 4 to 5 days a week, trying to just even keep her revenue where it was. It's hard to do because she's now treating young kids and getting into Airway and working with ENTs and allergists, and it's totally transformed her practice. But she says, I can't not do this. Once I saw it, I can't send this little kid, this 5-6-year-old kid who no one's paying attention to the orthodontist to just start pulling some teeth and just say, wait, and we'll fix it when they're older.
There are so many cases, Mike, that we are treating that it's like, this would 100% been a serial extraction case.
Yeah. Talk about that a little more if you would. Describe those cases a little more if you could, and how you approach them.
So it comes in a variety of ways, right? But if there's someone who finds us and their child is snoring, wetting the bed beyond the time that it's normal to be wetting the bed, kinetic during sleep, just not thriving, either hyperactive or sluggish, all these things that are clearly they're not developing appropriately. Then we will, look and see what's going on with the development of their jaws and their face, and we'll get in there and expand young, as young as 3.
Yep.
And we don't really want to. It is not fun expanding 3-year-olds.
Right.
But we do it, and it helps.
Yeah.
And it may not help 100% of them, but it helps a high percentage. And that's the kind of thing that in the literature we should find out, because the residents will get a study going, right? Because it helps them. And we get all the time feedback, they're not snoring now, they're sleeping better, they're not wetting the bed, they're doing better in school.
All the time.
Whatever it is, it's common. And so treating in the primary dentition, there is a value in it for kids who are not doing well.
Yes, thank you.
And you have no space between the primary teeth. You even have crowding the primary dentition and over closure, whatever, the mandible is back.
I remember I was watching a CE lecture with Mariana Evans who said something about if I get them and there's already recession or, it's too late. Sometimes it even happens at age 7, we see these kids that they have so much crowding on the upper lower, but you're like, oh, God, I wish I would have seen you 2 years ago when you were 5 and we could have helped develop that arch.
Yes.
So it's like that. We don't have to wait until 7.
Yeah. The alveolar arch is manipulable, and there's so much collapse and narrowness, and you can get in there and widen. First of all, you have the suture of the maxilla is like God's gift, right?
Yeah. Right.
And then if we were chewing and living the way we used to, evolutionarily speaking, we'd be wider, and there weren't too many toxins in the environment and whatever. There are a lot of living indoors, right?
Yep.
Is one of those things.
Allergic rhinitis, they're saying now it's upwards of 40% of children suffer from allergic rhinitis. And there was a study in, I think it was Journal of Clinical Otolaryngology or might have been otorhinolaryngology, that talked about over 80% of kids with allergic rhinitis have turbinate hypertrophy. So if almost 50% of kids are struggling from some sort of allergen giving them chronic inflammation in their nose, and 4/5 of them have inflammation of the turbinates, then their nasal breathing is directly impacted. And we can have an argument all day over, well, how much mouth breathing does it take to really change growth? The point is they shouldn't be chronic mouth breathers, right?
Right.
That's another problem, is that the norm is allergies. Oh yeah, everyone has allergies. Oh, then mouth breathing. Everyone's mouth breathing because they have allergies, and that's normal. But it's not. Doesn't make it correct.
Right. It's common, but it certainly shouldn't be accepted. And I want to just double back for a second when you said about treating kids 3 years old, because to me, yes, absolutely. And I'm a big fan of now going in and trying to get at these kids younger. But people in academia or who are in this sort of establishment organizations within our profession, or some of our colleagues, they hear that and they literally fall off their chairs. Or if they're riding the exercise bike, they listening to this, or on the treadmill, listening to the podcast, they might have gone down, because they're like, what, 3? And the thing I say to people, and then I want to hear a little bit more about what you've seen happen in that population and how the parents have received it when you've talked about that to them. They tend to say, well, there are no studies, there's no data that say that we should go in that young. And what I always say back to them is, really? Because I was on a cleft craniofacial team for 7 years, and we were going in even younger than that to remodel patients the way they grew, alter the craniofacial growth and development of these patients. So those patients had a craniofacial anomaly. They weren't growing properly, right? These patients, you're talking about these 3-year-olds with these high vaulted palates and narrow arches and trapped mandibles, auto-rotated down and back and not breathing properly. They have a craniofacial anomaly, or as Gimino calls it, craniofacial dystrophy. So they have dystrophic craniofacial growth and development.
Yeah.
And we know it's only going to continue and get worse as they continue to grow. We know that. There's plenty of literature and data on that. So if you are okay with going in on a patient with a cleft and working on their growth and development young as 6 months, where's the justification that we shouldn't be going in on a patient with a different type of craniofacial at, say, 3?
Yeah.
Right?
Yeah.
And no one ever gives me an answer on that. They just won't reply or won't respond, or if it's online or something. And because it's like, it's true. Like we do this stuff young. We go in as orthodontists and go in young on patients and help their faces grow properly. This isn't out of the box.
Well, like what also kills me is that we're doing these things and really trying to help with some, like, we think of what we do as like orthodontics for the brain.
Yeah.
And when the child is not growing and developing properly, it is affecting their brain development.
Yes.
And when we want to do these things, and there's this whole question around insurance coverage and all the machinations of how do we support these kids, it kills me that we're really helping them develop better and avoid so many outcomes that cost insurance companies, especially the adults we treat, my God, the money it costs them to treat the heart disease, the diabetes, the strokes, the whatever.
Or the car accident they get into and the insurance, right? Because they fell asleep at the wheel. I mean, it's endless, the list. Yeah.
Then it's endless.
One thing that we've been doing this year a lot is actually doing some lunch and learns where we're going into our community and kind of talk, because a lot of people don't know. Even pediatric dentists, a lot aren't really seeing it yet.
True.
And so it's been very fun to think of our cases that we really want to show other practices, to illustrate what we're talking about and what isn't the norm in terms of growth and development. And again, at these young ages, we know they're not going to grow better if we don't step in early, and so very early. So what do those patients look like even at age 4 or 5? So that's just been something I feel like we've been really passionate about as of late, is educate, because I know when it comes to our own colleagues of orthodontists, it can get a little, as we said, just, hairy.
A little contentious, yep.
I feel like in, talking to pediatric dentists or general dentists, it's like people are still just don't even know about it to some degree. So
has it been well received?
It has. It has been. And the question that people always have is like, what do we look for? Right? Like, how do we know? Because you sit there and you see it for a little hour-long lecture or whatever it may be, but then you go back to practice and you forget. It's about really showing other practices and dentists. These are the indications based on certain measurements or lip competence, looking at certain facial profiles and things of that nature.
And we always give them the validated health questionnaire, questions about does your child do this? Do what? It's validated, literature.
Yeah, that was one of the things in my part 2 of that article I referenced. Was trying to, it's hard in 2,500 words to explain this process of how to screen for these patients and what to do. But as I was putting it together, I wanted to highlight the most important, relevant things for people to look at. So I hope people use that as a way to help educate some colleagues, because it's not that hard. It takes time. But once we're all intelligent that have gone into this. Like anyone that's gotten into dental school and made it through is certainly intelligent enough to do the diagnostics required for this. You just have to know what to do. So I love that you both are going out and being proactive on this and not just sitting there like, why isn't anybody doing this but us? Like you're like saying, hey, look, like we have a responsibility to teach this, which I wish I did more of, truthfully, looking back. I could have been better at that, because it's really important that we educate those around us as to what we're doing, that we're not just going in and expanding 3-year-olds because we just want to start, we don't have enough patience, so we want to start treating kids younger because we've run out of 12-year-olds, right? Like that isn't it. It's because we can do things to change their craniofacial growth and development, their neurocognitive and behavioral growth and development. So what do you do? Because a lot of people with whom I speak, they say, and I'll give the caveat, we don't get trained how to treat, as Allie was alluding to, kids this young in residency. You don't come out of residency and start, like, oh yeah, 3-year-olds. We don't learn the behavior management skills. We don't learn the parent management skills. We don't learn any of that. I mean, the orthodontist sort of, the mantra is, teenage kid, mom and dad, you don't want them almost coming back because it makes things more chaotic in the clinic. The kid comes back, you ask if they're wearing their bands right, you check their hygiene, you do their adjustment, and they're gone. And when you don't, that's not how it works with a little one like that. Even if you're treating a 6 or 7-year-old, it's different than that. Yeah. So how do you approach it? How do you approach treating these younger kids, let's just say in even the 3 to 5 age range, and how is it received by the parents and by the patients?
What's interesting is that mostly the people who come are parents who want to know about this themselves. Like,
interesting. For the first exam, you mean?
Yeah, like they're here because they're worried in a way, like something is alerting them to this fact. Sometimes they're referred by a pediatric dentist, but it's a mix, right?
Okay.
So the parent is always obviously part of the process when you have a child that young. Some 3-year-olds we're not able to treat.
Yeah.
But most of them, I would say we are.
I also think it's like 4 or 5, I would say, is more common.
3-year-olds is not as common.
But a lot of those parents do come at they're like in millennial, right? They're on Instagram or whatever, kind of learning about some of this Airway stuff from a layperson perspective. So they come in and we kind of validate that in our way of showing them the 3D image. And when the little one's in the chair, I definitely don't have a lot of experience, or didn't have a lot of experience with kids, especially that young, because I didn't have a ton in my own family. Like I was the kid. So I've had my own journey of learning how to treat these little ones, both as like a doctor, but also just as a human. How do I act around 4-year-old?
That's the point with Allie. I'm like, you can be a bit more firm.
The parents in us are like, you got to draw a line. Boundary.
So I've definitely learned. I mean, I hate to say, I have a puppy, and so I actually learned by training my puppy how to speak more firmly to sometimes these little kids of like what I want them to do, or giving them positive feedback when they do. And actually, a lot of them have been quite like, parents are always like, I'm so proud of my little one. They're doing so well. I thought it was so hard.
Yeah, because they want to please at that age. Kevin Boyd talks about that all the time. Kevin's like, they still really they're in that developmental stage where they want to please the elders.
Yeah, and if it's like a Schwartz or something, like they get to choose their color or whatever. And we do go very slow. So it's not like it's not painful. No. Right. And again, it's common that they come back and they're like, that was so much easier than I thought. Yeah. And sometimes it's not, and there's issues, whatever it may be, of flicking it out with their tongue or something. But it doesn't seem to be the norm, and I don't feel like it's any harder to treat that age. But again, I haven't had too much experience not treating it. But I feel that for me, it was more of like, how do I present myself to these really little ones, and my own personal growth through that. But yeah, it doesn't seem like it takes longer or is more difficult in that sense, I suppose.
Yeah, and the main thing is also just structuring what does it mean then you're in the primary dentition, right? Like, how long do you expand them? What's your goal? They're going to need it again, right? Like laying out expectations. We're talking about a phase 1A and a phase 1B, that kind of thing.
Yep.
So it is like we're in an observation for after phase 1 for another phase 1.
And what about people who say, why not just wait?
because the kid is snoring and peeing the bed and not doing well, and that is affecting their brain development.
Yep.
And the making more room when they're that young also, like you get these kids later, even like it's harder to fix the degree of crowding when these kids are really crowded.
Yeah. Yes.
And so they're even having the central incisors are hooked on the B, right?
Yeah. Yeah.
You don't just talk about canine impact. This is the incisors aren't coming in. This is like classic serial extraction. It's like, oh, but that's not the right way to go.
Yeah, and go into that a little more if you would. Why is that? I completely agree. But explain if you would, why is that not the right way to go? The way we've been taking that approach, hey, look, the teeth are crowded, they're growing narrowly, remove some tooth mass. In your opinion, why isn't that the right way?
If you ask the questions, first of all, if you ask the questions of like in the health history questionnaire, I would say a very high percentage of them have yes answers. And we are then putting blinders on and only looking at the teeth.
Yes. Yes.
Well, also
Yeah,
the why of why aren't these permanent teeth able to come in? Oh, they don't have enough space. Why don't they have enough space?
We're a species that should have those teeth.
Right. This is a new phenomenon. For anyone out there that doesn't realize it, this is a really new thing that we don't have enough room for our teeth.
Yeah.
Evolutionarily speaking, this is real new. It's a microsecond on the spectrum of time and evolution that this has been a problem. So to think that this just miraculously evolved out of nowhere, and it's not cross-culture, interbreeding, it is not.
It's not the genes of your mom and then your dad and teeth right now.
Right.
No, it's
not it. Yeah. And actually going back to McNamara, he had a study in 83, I think it was, with O'Connor and Howe, where they took 104 patients and they had 54, I think it was 54 were crowded and 50 were not, or might be the opposite, but one subset was 54, one was 50, with severe crowding and with no crowding. And they measured the arches and the teeth. This was back in the days of plaster and casts.
Yeah, right.
And they looked at it and they found that invariably the crowding was not due to large teeth. It was due to deficient arch size. And they said we should take approaches that are less designed at removing tooth mass and more designed at getting the jaws to accommodate these normal sized teeth. And anybody who's been doing this a minute knows it's rare you're going to see a patient with general macrodontia. I mean, it's not something that walks in your door.
Yeah.
Hardly ever, if ever. And interestingly on that too, a lot of people say, and I want to hear your thoughts on this, but a lot of people say online, people will be like, well, there are no articles saying that extractions cause airway problems. And I say, why is that even the question we're asking? Shouldn't the question be, by extracting teeth, did we not take the opportunity to improve the airway problem? Right?
That's exactly the question.
Right.
That's exactly the question.
Well, also taking one step back, again, I've been out 4 years. I know it's not a ton of time, but every day I'm realizing more and more how much diagnosis matters. That is the core of what we do. We have to diagnose appropriately. Then everything's easy, right?
I agree.
And the diagnosis of, you're not diagnosing anything by just extracting teeth. You're just addressing an issue, but you're not, again, thinking about why. Why is there not enough space for those teeth?
Yeah.
And that's where I feel that how we're practicing is really so much time spent on the diagnosis.
Yes.
That means imaging. That means health history form. That means a good clinical exam and speaking with the patients, and then deciding on treatment based on that. So that's how I feel in a nutshell about that.
Yeah. And then what really helped clarify this also was having all of the CBCTs get rendered in a model form that we can move the teeth. You put those lower teeth on the jawbone where and you make the maxilla the width of where those teeth are, they fit.
Almost 100% of the time. I mean, I honestly don't know that I can think of, I can't say never, but pretty good at remembering this stuff when it comes to my patient cases. I don't know there was ever a time that I went in early, developed these arches, and normalized the growth and anatomy on these patients, got them nasal breathing through my own work and with work of my medical colleagues as needed, and these kids needed adult teeth pulled. it doesn't happen because you've set back the evolutionary clock almost, right? You've put them back. You've taken away all those things that have causing the crowding, right?
And that's the thing, that when we have parents who we'll talk about the things that we want to do, and then given a certain age, we might want to do something that's bone born, and it's like, oh, that's so aggressive. And I'm like, we genuinely feel that we're bringing them back to what nature intended.
Yes.
It's not like heavy-handed, manipulation. Then they actually can breathe better.
Yeah.
And the tongue is just so, have some reverence for the force that's creating.
Right. And we don't argue as orthodontists about the fact that when they are fully grown adults, they might need MARPE or surgical or MMA, right? But we don't argue about it then. I'm sure there are some, but it's certainly not a hot button issue that you hear us debating oftentimes, because we realize that if they have apnea as an adult, that in their narrow, high vaulted palates, you want to try to expand those patients. And if they're mid-face deficient, then you want to try to MMA surgery. So why do we argue about doing that when they're young? I honestly don't understand.
Helping them avoid being one of those, which is, exactly.
Right. And then all the comorbidities are going to develop along the way over those decades and decades of not breathing properly and not sleeping properly. To me, it's almost hard to believe when I hear colleagues, I'm not going to name names on this, but respected colleagues, highly respected colleagues, make comments like on a podcast, I couldn't get, not my podcast, I was listening to someone else's, and said, I can't get my 5-year-old to take ibuprofen. How am I going to treat them with an expander?
Oh, wow.
Yeah. And this is a thought leader in our profession who actually was advocating for what they call phase none, and that you do more by doing less was their approach. And that our profession is overdoing it. Also said that everybody knows that malocclusion is almost entirely genetic, that everybody knows that. I mean, this is a person, again,
that's crazy.
My point is not naming names in any of this, but it is someone you would know the name, trust me. And these are people that are thought leaders in our field. And I hear these things and I just don't understand not only on what basis they're making these comments, but why.
I mean, how could you say that it's almost entirely genetic? Like, there's such an epigenetic component.
I know. Have you heard the word epigenetics? I mean, it's like the definition of it, right?
Yeah, exactly.
Yeah, I don't know. I don't know. And it's kind of a rhetorical question, because obviously we don't know those answers in a concrete fashion. These are the things that just think about, thinking like, I hear the two of you speak. It's so in line with my philosophy. And all of us that are into this are so clear on it and so passionate about it and so enthusiastic about how we're transforming the lives of our patients. And then you go speak with some of our ortho colleagues who are like, don't you dare take a cone beam. There's no need for this. Or orthodontist has no role in airway. And I'm thinking, how can there be such a disconnect? And I'm not saying this in a condescending way. I'm really not. I really do feel badly for the people who don't ever get to experience what the two of you get to experience every day in your practice, which is that light that you're bringing to the lives of these families.
Yeah.
I feel so lucky that, again, just so early in my career, I get to practice this way. And even our staff, like, they see what we're doing and they get excited about it, and they're telling their families and friends, like, yes. People are going out there talking about it because they see it too. We didn't do all the training that we do, but it's so easy to see when you do see it. And
yeah. And what's also what I see, what you alluded to, I remember seeing that at the winter meeting was it Naples? It was in Florida.
Just south down in Marco Island. Yep.
Marco Island, that's right. And it's like, I was so heartened by the fact that we were having that meeting. And then I remember hearing some of the talks that were after the ones that I felt like, they're doing the good fight, and like, let's transform the profession. And then there were some other talks and I was like, that doesn't sound like great information. There are these like conclusions that are drawn in a way. It's like, that's not how the study should have been set up. And
yes.
Anyway, okay, so here we are, and I'm walking on the beach, and next to me, they don't know I'm an orthodontist, are a couple of orthodontists talking and walking, and I hear one go, so what do you take from that? And then the other one goes, sounds like we can just keep doing what we're doing.
justification, right? Looking for that validation. And yeah, they had a lecture there on the benefits of serial extraction. I mean, in 2025, we are really putting lectures on the benefits of serial extraction. To me, it's hard to comprehend that could be the way we want to go. And yeah, I mean, it's interesting though, and I want to hear your thoughts on this part, and then I want to get into a little bit about your practice model and some of the cool things you both have done in that arena. But when I talk about evidence basis, I had Roger Price on going back to Kevin Boyd, who had mentioned it, and then Roger Price was on fairly recently. He's a kind of Airway guru guy with the amazing...
I know Roger. I can imagine
awesome
what conversation was like.
The awesome Sean Connery voice. That is amazing. So he mentioned evidence basis and evidence-based medicine, evidence-based practice. And we've extrapolated that to dentistry, but it was really, from medicine was where that started. And he started talking about how it came about in the 70s. And I was like, I should look more into this. I don't really know what evidence basis is. And I would be willing to bet if you ask most of our colleagues, if you asked me a month ago, I would have said it is randomized controlled trials, systematic reviews, right? Good data, good literature from reputable sources. It's not what it is, not even close. When it was developed, Cochrane, who's now the Cochrane Reviews and Cochrane Collaboration, he kind of was the first one. He was a Scottish physician. And in World War II, he had done these random trials with yeast. And so he kind of had developed his own little experiments. And so he started talking about that. And then a guy named David Sackett in the 70s took that to the next level and started getting a little more in-depth on this concept of evidence basis. Well, the term evidence basis, actually, evidence-based medicine, was coined in 91 by a guy, the last name of Guyette. So it's new. It's a new concept in a sense. But Sackett wrote an article that said what it is and what it isn't, evidence-based medicine. And in it 96 in the British Medical Journal, he talks about the fact that it was being hijacked by the establishment, by entities who had something to gain financially from saying it needed to be tied to a certain study. He says definitively it is not randomized controlled trials and systematic reviews only. It is a tripartite. It is three pieces of clinical scientific evidence, clinical judgment and experience, and patient values and preferences. And all three of those circles are like a Venn diagram, with the intersection of the three of them being evidence-based medicine. It is not about just a randomized controlled trial. He even goes on to say that in the event a randomized controlled trial doesn't exist on a topic that your clinical judgment shows you could have a profoundly positive impact on the health and well-being of that patient, you are to trust your clinical expertise and judgment, taking into account the patient and parent values. So when people tell me now in academia or in wherever, like, I'm about evidence-based, you're not practicing evidence-based. No, you're not. If you're just looking at the data and the literature, I am, because I've done this for 2 decades in the mouth, in the real world. I've seen this and I've impacted the lives of many patients and families doing it. I'm taking all three of those things into account using sound biologic principles in craniofacial growth and development, tooth movement, etc., the patient values and parents who desperately want their kids to thrive, be healthy, and then my clinical expertise. So what are your thoughts on that?
Yeah, ditto. That's my thought on that.
Mm-hmm.
And I do, we talked about the health history form when they start. We had talked about a lot about like getting another version of that at the end, like more, because we ask these questions that contribute to that experience, what you were just describing.
Yeah.
Mm-hmm.
But it would be great for us to get this on paper, kind of in a way, like in an informal way, or maybe again,
like a standard exit, review specifically those questions, so that it can be used then. Even, I mean, nobody really cared. Like survey says was always the joke when I was a resident, like that it was a crappy study, just a survey. But it is helpful to know, especially when you're in private practice, like get some data on what was the outcome.
Yes. Well, we're so busy. It's so hard to do that in practice. That's where we need academia to step up and help us out.
Yeah. Well, one thing I would say that I didn't see anyone really do as much as Claire does, and now myself, is superphysicians.
Oh, yeah.
Physicians using the CBCT to really see, like, what did we do?
Yeah.
What are you seeing? What are some of the things you're seeing happen?
Well, we're seeing what we've been talking about. That we're expanding the upper jaw in a way that's contributing to increased nasal airflow. you see increased space around the turbinates. You see the tongue come up and out of the airway. Like you see these things over and over again. So is it in these studies that were accepted by some journal? No, but we're just seeing it because we're looking.
And developing the arches in such a way that the canines come in.
Yeah, thank you.
Is healthy.
Yes.
The occlusion is sound, like it's a good occlusion. You know, you're not like tipping. And that was the interesting thing to me about like the literature around, expansion, not expansion, And at University of Pennsylvania, the discussions about, you might cause some recession with doing phase 1. And it's like, okay, if you're talking about recession versus taking teeth out, I'm like, I would go for the recession. If you're talking of, get a graft. But when we're doing things with bone-borne expanders, you're making the tissue in the midline and the two halves are going with it and the tissue is there.
And when you start early, especially when their suture is a wide open highway, Melson's study in 75 talks about the infantile suture up to the age of 10. It's a wide open straight shot with no interdigitation. We know this anatomy. We know the younger they are, the more immature that suture and the circummaxillary sutures are. Why are we fighting doing this younger to only have to fight the biology doing it older? Like we make our lives so much. You alluded to that. Allie alluded to that as well. Like, we make our lives so much harder. I think Allie was articulating it by saying she was seeing these cases that just were like, this is hard. This is really hard. And then you start doing it more proactively and you're like, this isn't that hard. It's not.
Yeah. And the other part is like the dentist seeing all this beautiful dentistry they'd done breaking down in the adults.
Yes.
Because they didn't see the origination of what's going on that led to the need for that dental work, and then it just trashes it because they're grinding and they're not healthy. And
that goes back to just, again, thinking about the why. Like, why is this patient breaking down all their teeth?
Right.
Why are caries rampant in this, and their tissue all red and inflamed in this little 8-year-old, So it's just, I feel like we're always thinking about the why, and then that helps guide the diagnosis, which then helps guide the treatment that hopefully is sound, and these patients don't have to retreat again and again as they grow.
Yeah, I love that. Thinking about the why, not the what. I feel like we focus so much on the what. What am I going to do for this patient, right? What am I going to do? Not the why. Why is this patient like this? It's not just about straightening teeth in these patients. It's about so much more than that. And I feel like we're doing, and Claire, you alluded to this too, as the leaders in craniofacial growth and development in most professions out there, even beyond dentistry, right? And we go through so much education in that, and we're content to just lay up as being these glorified tooth straighteners that we don't want to look at this. It's like, guys and gals, open your minds, open your hearts a little bit to what we can do for these kids and their families, and just be willing to step outside your comfort zone. And I promise you, once you do, it is a whole nother world out there.
Yeah.
Yeah. Well, we have the luxury of that because of our practice, not like how Claire started the practice, really. It was started with this in mind. And I know as someone coming out of residency, having a lot of loans that they may need to pay for, like going into corporate, to help pay that. There are limitations that one might, you might want to practice this way, but feel like you can't for some reason. So I don't know how many people are in that situation, but I'm sure there are a few. And it's down to just not having the opportunity based on financial limitations, institutional limitations, whatever it may be.
That's such a great point, and actually a perfect segue into what I was going to finish up with, which is the business model that you both have. It is more traditional. Correct me if I'm wrong in any of this, but it's more traditional in terms of you have a practice that was established. Claire brought Allie in, and you develop an associateship to partnership. And so much of our profession today is being, I don't think taken over is the right word because I think that has a negative connotation, but the fact remains is corporate venture capital is definitely taking a big market share of our profession right now.
Yeah.
not outside of whether that's good, bad, or indifferent, it's happening. And there are pros and cons to that. And as Allie just alluded to, if you're part of one of these entities, you're really limited in how much you can change their protocols, their procedures, not just from a treatment perspective. People hear that, they think, well, maybe I can't use different brackets, or maybe from a diagnostic standpoint, if they tell you you've got to do your consult in 5 minutes, then you got to do it in that time. And so that's a great point Allie made. How do you both make it work? Because I really am a believer that this traditional practice model that you both are in really stands the test of time and will continue to. So talk a little bit about that, because a lot of young docs who follow my content, they're really confused. They have the debt that you just mentioned, Allie, quite a bit of it. I think the recent statistic I saw published was $567,000 is the average debt an orthodontist is walking out with right now, $567,000. So I guess we could kind of start with Claire and why she, instead of selling to a corporate, looked to bring a younger doc in that more traditional fashion, and then go to Allie after that of what was appealing to her about this type of environment.
Yeah. So for me, it was more that I didn't have a level of trust that if I went the corporate route, that I would be able to treat the way I want to treat. And also, I don't know. I think there's like a control element in there. Or maybe I could have. I don't know, because I didn't investigate it fully. Mm-hmm. But when I met Allie and we were working together, I felt like this was a much better way to go. And it does feel like, the whole HR thing, like it's hard, right? It's hard running a practice.
It is.
And what also kills me is that like the corporate entities get things at such a lower cost basis.
Agreed.
That drives me nuts. It's like you're giving it to them for half.
Yeah.
It makes me crazy. Not only that, but they have access to better healthcare to be able to provide to their employees, because they're this large group instead of a small group. And anyway, that's a whole other long conversation. I don't feel like I'm hugely knowledgeable in the business choices between keeping it as a private entity versus going in a corporate mode. It was much more of a personal decision. Mm-hmm. And we certainly have a model that it works. Mm-hmm. And I also feel like people who come to see us, they want that kind of personalization. And I think within a corporate entity, it becomes so much more about efficiency and the bottom line that it starts to take away the high touch part of things.
Yes.
And it's important to us to be able to have that in what we are doing. And it's what's needed. It feels like it's what's needed in healthcare. Like it's just not going the right way when a doctor is only allowed, physicians are only allowed to be in there for 5 to 20 minutes, maybe.
Right.
And not really hear what's going on with a particular patient. It's
right. And that's why a lot of these offices don't have cone beam, because the ROI, I'm sure we all could attest to, is indirect from CBCT imaging. So
I more than made up for what the CBCT cost just in my records fees.
Okay.
It's a moneymaker. Which
I love that. Unfortunately, a lot of practices are not charging for records, so they look at it from a corporate. I agree. But a lot of the corporates, especially, they're like, we need to get the volume, get these patients in. They're marketing free records, free consultation. Yeah. So to have them then have the incentive to invest in very heavily in the front end of that practice to these expensive machines, and then as we know, you have to buy software for the computers. That's different. You have to train your staff differently. You have to have different protocols and systems. You need more server space because they're large files. They don't integrate as easily with their practice management software. So for a corporate, the word you said there was that control, but you want to have control over how you treat your patients. And I was the same exact way. I got significant offers from corporate, but I just was like, maybe it's a flaw that I'm that much of a control freak about it, but I never wanted anybody saying what I could or couldn't do for my patients. That freedom is everything. And I'm not, again, bashing corporates or bashing the private practitioner. I'm just saying there's pros and cons to each. And I think everybody needs to do what I feel did a great job articulating, is you knew yourself. You knew what you wanted and what your vision was. And then you fought for it. Yeah. So Allie, what was appealing to you about a non-corporate model, more of a traditional solo doc practice to go join?
Yeah, I thought, but I didn't want to be a practice owner. What Claire was talking about herself earlier during residency, and it was very clear after a few months of private practice in different offices that I was like, I can't do this for the rest of my career. So I didn't know that this was going to happen so soon, that I would be in, practice, partnership, and all that. But I remember when I was looking for work, because again, I threw out letters everywhere and doing that whole thing. There was one corporate. It was like I would have to drive an hour and 20 minutes, but I'd get paid significantly more than the per diem at the private practice that was 20 minutes away. So I was like, should I do it? Because of course, all the things that a resident or someone is thinking about, it would help me pay off my loans. It would help me just enjoy life now that I'm not a student. To some degree, I feel bad about not having money, those things. But yeah, I also don't know too much about it because I never did it. But I would say that, I'm glad I didn't do it. And I feel that there's still a balance between running the practice efficiently and having that high touch aspect.
Yeah.
Yep.
Of the two of us, I am the more businessy, she is through some of that efficiency type stuff that I think is kind of a hot topic in our profession. Maybe it's always been that way, but it seems like it is right now. But there's a balance. There's always a balance to these things. And it's always about how can we still have an efficient, well-run practice that's organized and have our systems and all that good stuff, but have the flexibility to spend more doctor time with our patients. And it's not okay, doctor time's over, time to go on. It's we have a flexible schedule. There's two of us, right? He's busy with the patient and there's an exam. I'm going to go hop in and do the exam while Claire's finishing up with that active. So it's fun that we can practice that way because we have flexibility, and we do charge for that, for the exam. Right? I think all orthodontists should charge for exams. If you're only in there for a minute, then it makes sense, but you may not charge for anything.
Right. Yeah, I think that happens. And do you guys charge up front so if they come in and pay that day? Is that if they're told about it in the initial call? Okay, good.
They're told about it. And we don't.
And just let me get this straight. You're not finding that no patients will come to see you? Is that
We're not finding that.
No.
Because that's the fear. I'm obviously being a bit sarcastic in that, but that is the fear a lot of orthodontists have is, oh my God, if I charge for records, no patients are going to come see me. So. And
it's so not true. It's Claire owned what the practice model that she wanted, and it just has that confidence and this is what I believe is why the practice is successful. And so it just, people will still come and they still do. And those that are not wanting to pay that fee, they will not pay our fees for treatment then. Right. And we don't waste time on that exam. Right. So
and
it really works out.
And I'm sure you script it this way as well. We found when we explain that there's a fee for our records and diagnosis, it's because the doctor puts additional time into that process.
Exactly.
Right. Like you guys just said, if you're in there for a minute, how do you exactly charge for your time? I mean, you can, but you're going to leave a lot of people well, that was a ripoff. But if you're taking a 3D image, you're going through this comprehensive health history, your TCs are doing a lot of and patient coordinators are doing a lot of the pre-screening, then you're going through it all with the patients and reviewing. People understand your time is not free.
They'll be like, wow, this isn't what it was like when I was treated or the sibling was treated or whatever. They are grateful.
Right.
And happy to pay the fee.
Yeah. And a lot of times I'd have people say for your time, I'm surprised that's not more, or what you did here. They get that. And I agree. And Claire, you had alluded to this before, but people are starving for this type of attention in healthcare right now. I mean, any of us, you go to the physician, you take your kids and my goodness, it's a miserable experience from a customer service standpoint, from a medical standpoint. It's terrible. It's very rare to find really good. And there's outliers out there, obviously, but the overall feel in our professions, the medical dental profession, can be really unpleasant. And I feel like we have a spot when we stay independent, as you both have, that you can call your shots. You can do what you want to do. There's nothing like the price of that autonomy and that freedom, really.
Yeah. It's one of the other great things about being in dentistry that we still have that model that hopefully doesn't fully go away. But as you said, it is trending in a different direction, but it's more fun to practice this way and better for our patients.
Yeah.
Yeah. Well, the way you two are doing it, I'm confident to say that will never go away, because human nature is human nature, and people always want to be made to feel valuable and important. And they know when they feel like a number. We all do, right? And they know when they're being valued and helped. And as long as you're offering backing, you got to back it up, right? You got to back it up. But if you're backing it up as you two are, with the level of service and the exceptional quality of care you're providing, then people will always seek that out, right? And it may not be the highest volume. You obviously, if you're doing $2,000 braces or aligners on everybody that walks in, sure, you could have all this volume, but what type of practice do you want, and what type of feel do you want your patients to have in that practice?
Yeah, and what it feels like is that, like, we really do care, right? About our patients and what's going on in their brain and their body. And if you have a model that's just more and more and more and more, and like it's infinite growth kind of thing, you're too overwhelmed. There's only, you're one human being, Yeah. So it's got to work. It's got to work in a way where you can still stay healthy yourself.
Such a good point. I've been guilty of that myself, right? We put ourselves in the back seat, so to speak, on that, and get so focused on the practice. So that's such a good message to the young docs out there, especially. We feel like a lot of times we can't have it both ways, but it's because we don't choose to, I feel. And I'm not pointing fingers. I've been guilty of it myself, but yeah.
Yeah, no, and me too. But it's one of the big limitations or stresses, it feels like, that I hear from other providers who really do care about this, and they're trying to figure out how to get into it. And it's like, they're afraid of, how do I deal with the fact that they may just go right down the road and choose, like, they don't have the name recognition in a way that people will come because they've heard it's better.
Yep.
So it's a delicate thing that in this transition we're going through.
Yeah.
And some people I've heard, it's like a lot of overwhelm. So
yeah. Well, on that, how can people, if they have questions, can they reach out to you on this? How can people get in touch with you if they want to learn more about what you both are doing or how you're succeeding in this as you are?
Yeah. What do you think? The info?
Yeah, we can write our email.
Yeah.
Okay.
Yeah. We're going to give our contacts in your show notes or something.
Perfect. Yeah, I can just put the email in the show notes. That sounds great. A link to the website. This has been really, really fun for me. I give you two so much credit for what you're doing, and Claire for setting and blazing the trail and knowing your vision, what you wanted to create, and doing it. And Allie, being young and taking that step and stepping into this. You're such an inspiration for the younger docs that I train and coach to say, hey, look, this is a thing and you can do this, and really find it very fulfilling and enjoying to be able to take this step in your career. You both are an inspiration. I mean that.
No, thank you, Mike. And thank you for bringing it more to the fore, like having a voice that has a platform and educating. It's huge.
Yeah. You're welcome. It's my pleasure. Love doing it. And I get to meet and interact with people like yourselves. And I'd be remiss if I didn't say too, great chapter in George Menelaris' textbook, by the way, that Claire wrote. George, actually, ironically, his episode will be coming out a week before yours. So I did not plan that. It just happened. But we talk about his book in there and your chapter in there. It was spot on. I loved it. So well done.
Thank you, Mike.
Yeah, no, great. Well, thank you both so much. I really appreciate it. It's been a pleasure.
Good to talk to you.
Thank you.
Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.